Hey guys, welcome back. This is Larry with Critical Care Connection. Today we're going to be talking about arterial blood gas. We're going to be making this into a two-part series. So part one today is going to be talking about how the numbers of an ABG are formulated, what is made up of an ABG. We're going to talk about the ins and outs of all the systems responsible that make these numbers. And then in part two, when we go back, we're going to do interpretation. We're going to take the numbers that we've got and we're going to decipher whether we have metabolic acidosis, respiratory acidosis, so on and so forth. And we're going to give you the methods that you can use and how to interpret them and feel confident in your everyday use. So a couple of it, well, I guess it was last video, we were talking about a giveaway. So we did a random drawing and we came up with a name of Shane, who is actually one of my buddies that I know from way back. He left one of the comments in the section, so we're going to be doing the giveaway for Shane. So I'm going to reach out to him and let him pick out whatever shirt he wants from the store that we have. And we're going to be doing this a lot. So please stay tuned and let's get into our live action right now. All right, so you want to be good at interpreting ABGs. You want to understand ABGs. This is our first starting point right here. We need to look at these values and we need to learn what they are. And we need to memorize them. If you need to write them down a couple times, if you got a good memory, great. But I think after you do them a couple times, the numbers are pretty well, they flow good, so they stick with you. So you should have no issues after doing a couple of these. So let's talk about this. pH 7.35 to 7.45. That's your golden range. That's life-sustaining in between those very fine numbers right there. So PO2 is the amount of oxygen in the blood, and that's measured at 80 to 100 millimeters of mercury. PCO2, this is the amount of carbon dioxide, so CO2 dioxide. So this is what is considered the acid. So this is 35 to 45 millimeters of mercury. Now, this is kind of a respiratory number. This is what we breathe off. Every time we breathe in, we breathe out CO2. So just think about respiratory acid. HCO3 is bicarb. So this is going to be your base. So we're going to be talking a lot about acids and bases, because what is this all about? This is all a teeter-totter between an acid and a base to make everything happy. So on this one, 22 to 26 milliequivalents per liter. And then you have an O2 sat, which would be your sat that your oxygenation is showing on your monitor. And then you have base excess / deficit. And it matters only to which it is. If it's positive, it's an excess. Negative is a deficit. Just like when we talk about the carbon dioxide is specific to looking at the respiratory status, base excess is going to be an indicator of your metabolic status, so your metabolic base. So if it works the same way. So if you're in the positive, you have a higher amount of base. If you're in the negative, then you have too little base. So these numbers are going to be super helpful when once we get into part two, where we start looking at interpreting and trying to decide what type of abnormality it is. This is going to be super helpful. So let's move on. This is all about essentially pH. We look at all these numbers, but the one that we really care about is the pH. So when you're talking about an ABG, ultimately we're talking about the pH, and our bodies rely on this pH to be correct to pretty much perform anything and everything we do every day. So what is a pH? So pH is a scale that was made up from a 0 to a 14, and then so you've got an acidic side, you've got a base side, and you've got a neutral right down in the middle. And this is all made up of kind of a measurement of hydrogen ion concentration. So hydrogens are acids, basically. So we want a pretty even level of acid and base to give us this feng shui, even, neutral ground. So on this scale, you'll see a 7 is considered neutral just by whole numbers. Like I said before, for us as our bodies, 7.35 to 7.45. Our middle ground would be a 7.40. But I like this scale because it makes it a little easier so you can kind of see the difference. So our bodies, again, pH of 7.35 to 7.45. This is normal. Remember that. So now let's talk about what if we had a pH of less than 7.35. Think back to our scale. What will we be at with that? This would be acidosis because we dropped below. Acidosis is your lower numbers. So that would be an acidotic state. So this is, of course, when there's a buildup of too much acid in the body. So adversely, if we talk about this, what if we have pH of greater than 7.45? Now we have alkalosis. So now we're on the other side of this. This is more of your base side. So then there's too much base in the body. So we have more base than we do acid. This leads us into alkalosis or an alkaline state. Now, two regulating systems for pH in the body. There's lots of things that contribute to the ups and downs of the acid-base balance. These two guys right here, these are going to be our biggies. This is what helps control most everything that we do with acid-base. So we have the kidneys. They're your considered metabolic side. And then lungs, of course, matches up perfectly with your respiratory control. So these two are going to make up a lot of what we talk about when we decipher an ABG. So let's talk about lungs first. So in the lungs, you exchange gas. So we breathe in, and when we exhale what? Carbon dioxide, or carbon diacid is another word for it. So as we do this, our body is regulating with each breath the acid-base balance. Now, for someone that's breathing too fast, they're going to be blowing off more acid. So this would cause them to be in a base excess kind of state. Now, vice versa, if you have somebody that's breathing too slowly, then they're going to be holding in that carbon diacid, and they're going to have a buildup of acid then, so that would put them in a acidotic state. So the lungs are considered the fastest method in controlling pH. So they can have a swing and correction in several minutes. It's that fast. So the lungs inhale, exhale, and they control your acid-base balance by lowering or raising your respiratory rate. And this will help even everything out from a respiratory standpoint. So a person that's breathing rapidly is tachypnic. So this could cause respiratory alkalosis. And it's going to cause that because we're doing what? Breathing fast, blowing off too much acid, and now we're going to have more base than we do acid. More base means alkalotic. And what's this going to look like on your pH? You're going to have a higher pH because more base is a higher number on the pH scale, right? So what are some of the causes that can come? Anxiety attacks or panic attacks. They cause rapid breathing. Pain, fear. Mechanical ventilation is one of those things that sometimes we don't know that we're doing too much sometimes until we look at the numbers, and then we say, oh, well, maybe we need to take it back a little bit. We're now in an alkalotic state. we can bring their vent settings down a little bit and kind of fine tune them from there. Heart failure, PE are also some of the contributing factors to people that are in respiratory alkalosis. So if we look at on the other side, a slow breathing pattern we call bradypnea. This is going to cause what? Respiratory acidosis. So blowing off too little acid because we're breathing too slow. So this is going to say our pH is going to be lower because we're on the scale. We're going to drop below 7.35. So now we're going to be in acidotic state. So this would be respiratory acidosis. So causes of this, asthma is one, COPD, mechanical ventilation. Again, we can go high, we can go low, we can do all kinds of things with the ventilator, and sometimes we just need to see what our numbers look like to know whether we're doing the right things. CNS or central nervous system depression. This is probably one of the bigger ones outside of mechanical ventilation. Alcohol use, drug use, anything that kind of slows that drive down. These folks are going to have a buildup of acid. Sleep apnea, also a big one. Pneumonia, anything that is going to impair gas exchange inside the lungs is also going to cause us to be at risk for respiratory acidosis. So let's talk about your metabolic component, which is going to be your kidneys, right? So kidneys work by elimination of two things, hydrogen molecules or atoms. Remember, hydrogen, acid. And in the thing here, we've made everything acidic is in red and base is in blue. So hopefully that'll help you remember a little bit better. And then you've got your HCO3 or bicarbonate. So the kidneys work essentially by excreting what needs to be excreted to make everything even. So let's say you're in an alkalotic state. Let's say your kidneys are now trying to compensate for like a respiratory alkalosis. So it's going to excrete and get rid of more bicarb and have a more heavier concentration of acid. So it's going to try to outweigh the base that you already had an overage of, and it's going to give you more acid by eliminating the bicarb. So this is trying to work to bring your balance back down. The only downside to the kidneys, they're slow. They just don't work as fast as the lungs, and this can be altered by kidney function as a whole. If you don't have great kidneys to start, it's going to take a lot longer for them to try to correct. So this can go over a period of hours or up to days sometimes. So if we're going to talk about metabolic acidosis, so this occurs when the body retains too many hydrogen ions or the body loses too much bicarb, leaving more abundance of acid. So some of the causes of this, diabetic ketoacidosis, lactic acidosis, intoxication of glycol or similar components. People with kidney disease or kidney failure, they have a hard time with this because their body's not able to eliminate acids as well as it once was. Diarrhea is one. The gut itself maintains and holds a lot of bicarb. So of course, if we have diarrhea, we're eliminating that bicarb, leaving us in a more acidotic state. Rhabdo, spirolactone diuretics, getting rid of more urine, you're dumping out more, and then shock states as well. Hey guys, let's take a time out for just a second and talk about this. So when we're talking about metabolic acidosis, and shock and lactic acidosis gets brought up a lot. These are big things when you start seeing these patients in shock states. So how do we get from point A to point B and into a metabolic acidosis with shock? So think about it real simple. So any type of shock that you have, you're having an altered flow of oxygenated blood throughout the body. So these tissues that normally require oxygenated blood are having to work with less than what they had before, right? So now we're making a transition of aerobic breakdown or metabolism to anaerobic metabolism. They don't have the oxygen supply that they once had. So once they shift over to anaerobic metabolism to try to continue to create energy for the body and let the organs do what they're supposed to, now with this anaerobic breakdown, they're starting to release acids into the body because it's a byproduct of anaerobic breakdown. So decreased oxygen, anaerobic metabolism, trying to keep up with normal demand, now is producing these acidic metabolites into the body. So now they're just flowing all through the body. Now we're seeing where we get this from. Now we're seeing why we have a metabolic acidosis. So hopefully that makes a little bit of sense, clears it up a little bit for you. So if we look at metabolic alkalosis, so now we have an issue where the body's retaining too much bicarb, or we're losing acid from somewhere and it leaves you with an abundance of base. So excessive vomiting is one, because in the stomach, what do we have? Acid. So this is what helps us break down our foods. But if we're constantly vomiting this acid up, then that leaves us with none. So you would think now we're in this risk for having a higher base. And same with NG tube suction. It kind of falls in the same line. If we have a patient that we have just constant suction to, we're never having any acid buildup. And this is just one piece to the puzzle, but it can lead to an alkalotic state. Diuretic use, just like we had with the acidosis, it can also excrete more acid or hydrogen ions and then leave us with an alkalotic state. And then potassium depletion as well. Alright guys, that's a wrap on part one of how to understand ABGs. The how, the why. Hopefully now you have a little bit better understanding of both of those. And moving into part two, coming up soon, we're going to be doing the interpretation. So we're going to take what we learned today, we're going to put it into part two, and then we're going to figure out how the heck do we interpret these things. So in the next couple of days, stay tuned. We're going to put out part two. And if you haven't subscribed already, what are you waiting on? Get out there and subscribe. And then, as always, I enjoyed your company. We'll see you on the next one.